tonight, ankylosing spondylitis. So, ankylosing means stiffening, and it comes from the Greek word ankylos, which means bent. And so, spondylitis means inflammation of the spine. So, together, we are then having this spinal stiffening caused by inflammation. So, a chronic inflammatory condition of the axial skeleton, which is your spine and the pelvis there, which results in new bone formation in areas where you otherwise wouldn't get that type of inflammation.
Yeah.
So yeah, and it usually starts in the lower part of the pelvis and then begins to make its way up the spine there. And I'll just let Dr. Roach jump into the x-rays now and explain what we mean by that.
Yeah. So with ankylosing spondylitis, and people typically will abbreviate it AS. So don't confuse it with ALS or MS. This is AS for ankylosing spondylitis. And ankylosing meaning, fusing, I think you said, Ben.
Mm-hmm.
Yeah, bent, spondylitis, inflammation. You are going to get what's called formation of what's called syndesmophytes. And if you remember looking at some of the x-rays that we shared with you, and actually you can kind of see a normal looking, lower back here, right here. And here you can see that there's like a candle wax dripping appearance over here and over here. And you can tell that the spacing over here is being connected by bone on either side. That is what we call those syndesmophytes. So imagine now a spine that's meant to bend and rotate, that now has vertebrae connected to one another. Obviously, the mobility is not going to be great. So we have what's called syndesmophytes starting to fuse the spine. Where you're going to start seeing that is an area called the pelvis, specifically the SI joint. So I'm going to orient you a little bit as to where we're looking at here. This is called the SI joint right here. It stands for sacral, and that's the sacrum, iliac, which is the big bone over here. So right over here, you will see the joint, and it's right over here as well. I'll just make two dots right here. You can follow the line of that SI joint right in through here. The first thing you're going to see with somebody who has AS is starting to fuse these joints called the SI joints. So as you can tell by these arrows right over here, there is no joint there. So now that person doesn't have the ability to move in through these joints right over here.
Mm-hmm.
So that is crucial, because what ends up happening is typically low back pain. And then later on, you're going to start to see fusing these things over here a little bit further up. And it's going to start at around T12, and then it's just going to spread throughout the entire spine. Ben, do you want me to talk about the ALL, the anterior longitudinal ligament?
Yeah, sure. So ALL, anterior longitudinal ligament, is the ligament that lies along the anterior, the front aspect of the vertebral bodies. And so it'll create this sign on X-ray, a trolley track sign or a bamboo spine. But essentially that area will get targeted and it'll begin to ossify and fuse to one another. And so when you're looking at the spine from front to back, it's difficult to make out, but you can make out some of that fusion, like where Dr. Roach drew there. And that's actually the fibers of the disc fusing, which is pretty cool. Bad for the person who has it, but cool for us chiropractors, because the ossification starts from the bottom of one vertebral body and runs right to the top of the other, which is really uncharacteristic and of anything else besides just this condition, which is really interesting.
Yeah, so if you're looking straight on at somebody, the part of the spine that's facing the organs, there's a long ligament that goes all the way down the spine. So as that ligament starts to ossify, you can imagine that you start to get the appearance of being bent forward, because the ligament is able to move when it's not ossified. But when you start to turn that ligament into bone, it starts to bring you forward. So
Mm.
that ligament would lie right in front of here. So the ligament would go all the way down. And when that ligament starts to ossify, the vertebrae start to bend towards the middle, and you would start to see a curve.
Yeah, yeah, definitely. And then structural changes begin at that point because now our spine is out of alignment. And so this condition, the onset is usually younger. And so you'll start to notice pain in a younger age group, which should trigger, you to think that there's something weird going on because it's not always common to have a lot of back pain in younger individuals. And so you always want to do your due diligence and take an image so that you know what's going on. So the onsets between 15 and 35.
Mhm.
Usually men are targeted much higher than women, 3-to-1 ratio. And it's a pretty debilitating condition, as you can tell from some of the X-ray descriptors here.
I think that's the first condition that we've talked about that men are more at risk because we've talked
Yeah,
so many that women are more at risk. So again, so this is the kind of intro to ankylosing spondylitis. So the high points, let's just summarize. We have a bamboo looking spine where you can see kind of like the ripple effect of this ossification called syndesmophytes. You have the beginning of fusion of the SI joints over here, and the fusion or the ossification of the ligament on the front of the spine that's now going to start to change your shape and your posture into that bent forward looking position.
so so during the exam, what kind of things, what are the things that we'd be looking for to help determine if an individual has regular low back pain or if they have a condition, an inflammatory condition such as AS? So the history will show an insidious onset of low back pain. So no cause, no trauma, nothing like that. That's not really different because we see a lot of people who have low back pain and have not had trauma.
That's the
And
majority.
also, yeah, especially in our clinic, and greater than 3 months. So that means that it's chronic, and this is a chronic inflammatory condition. So it has to be greater than 3 months. Anything less than that is more acute. Patient under 40 years old, and there's possible eye involvement. So AS is an inflammatory arthritis. So we have to think about inflammatory conditions. So other inflammatory conditions are Reiter syndrome, rheumatoid arthritis, psoriatic arthritis, right? So you have to think about the involvement of the organs as well as the soft tissues. And so uveitis, which is inflammation in the eye, possible condition that may be associated with that. So we have to look out for that.
You want
Yeah.
to go? Yeah, so the hyperkyphosis. So we have two types of curve in the back. One is called lordotic. So that would be the one in the neck and the one in the lower back. And we have two kyphotic curves, which are the one in the middle back and your buttocks, so your sacrum, right? So the spine will take a hyperkyphotic look. So from the side, you're going to have a large hump from the bottom part of the neck in through the mid lower back. Definitely inflammation lower back, which when there is inflammation, as we know, there is pain. So there is no pain without inflammation. So when there's pain, there is inflammation. And general malaise. Like I've noticed that with some of my AS patients that, some days it's the lower back, some days it's, joints in the neck. And so it can kind of flip flop, and every day can be a little different than the last day. And
Yeah. Yeah. With this condition, I was going to say it's one of these conditions where it can go up and down. Some days it's good and then some days it's bad. So whenever you're doing any sort of treatment and especially, taking care of patients like this, it's always good to make the best of your good days.
yeah,
That way you can sort of get everything done and get the movement that you need to get through your spine. Just going back, patients feel really stiff in the mornings usually, and then that tends to go away throughout the day normally in this condition.
yeah.
And like we said, we want to be able to check the SI joints because that's where it starts. They'll likely have pain there. We also do things like a forward bending test. So we want to see just how far you can bend forward, how much flexion and extension and flexibility do we have in the spine.
Yeah.
We're also checking the cartilage of the ribs because in a condition like this, it affects the joints of the rib cage. And so we want to be able to assess, okay, how is the breathing? How is chest expansion? Because as you can see, for our man that's in that lower photo there, when you're bent forward, there isn't a lot of chest expansion that can happen at that point.
Yeah. And that brings a point too that, you can't forget that the rib cage articulates with the spine. So there's a joint there. So as you take a deep breath in, that expansion needs to be a certain amount of centimeters. And when it's short of that, you have to question why is that, right? So definitely, COPDs, chronic obstructive pulmonary disorders can also cause that. But then you go with your health history and see what else is going on. And one thing to not forget about is because this is affecting the spine and you've got major syndesmophytes and fusions happening all over the place, these types of people can get stuff like sciatica, pain going down the arm. So they could present just like any other person would with neck pain that's radiating to the hand and fingers and low back pain that's radiating to the lower back or sorry, to down the leg because you can have nerve roots that are irritated because of the amount of ossification that's now happening in the spine.
Mm-hmm. Yeah. And so if you're not being careful, you could treat the condition, think that it's an SI joint. And I mean, this happens in chiropractic offices all over the world. And, because we treat an SI joint commonly with most sciatic conditions.
Yeah.
Um, and, so it's very important that if you have any hallmark signs of an inflammatory condition, that further investigation be warranted.
Yeah.
And I think that's what the next slide is about.
Yeah. So one more thing is typically when these conditions get a little bit further, specifically with AS, because of the fusion of the ligament, if you were to lay down on your back, you will not be able to do a sit up because your spine can't bend because the ligament is fused. You don't have the ability to roll yourself up. So you're almost like a turtle on its back, and you can't get out of that position because of basically the physiology of what's happening with that condition.
Mhm. So just as a little break, I hope everyone's enjoying this presentation so far. This is a really cool condition, something that we talk about oftentimes in chiropractic colleges, and it's also there's courses offered out there to help medical professionals be able to determine much faster these types of conditions. And so, if you guys are enjoying this, give us a like and a share. So thank you very much. So when diagnosing the condition, the first thing that you would do is likely image. And so you want to be able to check to see, okay, are the SI joints fused? Do I see any of these syndesmophytes in the low back? The next place that you can check clearly is the neck. And as you can see in the photo to the left there, you see how that ALL as well as the PLL, there's fusion. So the anterior longitudinal ligament and the posterior longitudinal ligament, as well as ossification of the discs. So
So
it's
let's
really
take a
cool.
little poll here. Which one do you think
Mm.
AS and which one do you think is osteoarthritis? So in the comments section, we want you guys to tell us which one is just degenerative disc disease, not AS. Is it the one on the right? So put R for right or L for left for osteoarthritis, degenerative disc disease, not AS. So we're just going to wait for a few seconds here to see how many of you have become radiology experts.
Little participation, right or left, L or R.
Which one is osteoarthritis? The one on the right or the one on the left? R or L?
Which
Oh,
one? So we got right. All right. Who agrees?
Good job, guys.
Excellent.
So yes, it is indeed the one on the right. So if you recall, I'll just do a few little annotations here. This is the disc space. This is the vertebra. We have 7 vertebrae in the neck. 2, 3, 4, 5, 6, 7. This guy's not faring off too well. And the reason I say that is because you've got very, very thin spacing right there, very thin spacing right here. And you've got what's called spondylitis here, anterior spondylosis right there. And you've got scalloping here. This guy probably has some numbness and tingling going down the hands. He's got absolutely no curve in his neck. He's actually got a reverse curve going this way. This is a good review for some of our other Hump Day conversations. Here's his hyoid bone right over here, just as an anatomy thing. And this guy, you can tell, has a lot of forward head posture. Where's the inside of the ear? It's hard to tell here. It's called over here. And you draw a line all the way down. Here's the top of the shoulder. So his head is probably at least 2 to 3 inches forward. So not a great looking x-ray here, but definitely this is the one with AS. And what Ben was saying is that the ligament on the front here is all fused, and you don't see the opening of the disc space, right? There's no opening because this is fused right here. This spine does not move. Now, the only place you see that there's actually an articulation is actually right here between C1 and C2 in the dens. This is a little bit more advanced, but you can't really see it here too much. But C1 and C2 usually are not involved with AS, as well as COC1. But from C2 down, this is one vertebrae really moving all as one unit. And you can see it here in the back as well. You can see some facet arthritis over here. You can still see the line there. So this is a mess.
Yeah. Yeah, and that was a great explanation. So, yeah, we use x-rays to help compare, right? We want to compare to normal, and those are hallmark signs that we look for on imaging. So the first thing that somebody would do is send you for an x-ray, see if there's any involvement, any joint involvement, and any signs of AS. The next thing that a prudent doctor would do after doing such thing is they would then send you for blood work. And so the first one that's very common among people with AS to check for is HLA-B27. It's used as a marker for spondyloarthropathies. And so these are arthritis in the spine. So things like inflammatory arthritis, reactive arthritis, psoriatic arthritis. So they're looking for proteins on top of white blood cells, the B27 protein. And so somebody who has AS will test positive for HLA-B27. ESR, yeah, just to talk about blood work quickly here. These are 2 other ones as well that prudent doctor would also send you for. ESR, which is a marker of increased inflammation. It's not a test for AS. It's just to tell you, okay, yes, there's increased inflammation in the body here, so there's likely an inflammatory condition involved. And then rheumatoid factors. So again, it's not a test for AS specifically, but it can help rule out other conditions and spondyloarthropathies like psoriatic arthritis. So if you test positive for rheumatoid factor, you could test, it means that you could have an inflammatory condition, but not necessarily AS. Right. Yeah. Because AS doesn't, like AS is the only inflammatory spondyloarthropathy that tests negative for rheumatoid factor. So if you have an inflammatory condition and test negative for rheumatoid factor, you likely have AS.
That's a great point. That's a great differentiator there. And ESR, guys, stands for erythrocyte sedimentation rate. Basically, to make a long story short, if you had blood cells in the vial, it's how quickly the red blood cells fall to the bottom. If they're thick and molasses-like, then we have inflammation. It's very, very slow, right? So, yeah, great. You know, this is how we differentially diagnose a condition. like AS. Yeah, so I can touch base on this, Ben. Addressing the whole person. I always tell people that we don't treat the condition, we treat the human being. We don't treat an X-ray. We don't judge the X-ray and assume that a person is going to be a certain way, because what's lying on our table is not an X-ray; it's a person. So one of the things that we can definitely do with AS is suggest dietary changes to a more anti-inflammatory diet, because obviously AS is an inflammatory condition, um, that basically, one here has been put in a study published in February in 2019. Journal in Advances in Rheumatology found that high fat diets resulted in worse disease outcomes for patients with AS. Now, we have to clarify that those are not good fats like avocados and stuff like that. These are like trans fats and stuff that we are not supposed to eat.
Yeah.
But definitely reducing your intake of any of the white stuff like flour and sugar, processed foods, and going towards more a paleo style diet is definitely going to help reduce the amount of inflammation in your body. And one thing you can do very easily is go on Google and type in inflammatory foods. And those are the foods you're going to want to avoid. Some of those might be nightshade vegetables. So it depends on the body in terms of how you're reacting, because some people know when they eat certain foods that they become inflamed, and people that pay attention, that have inflammatory conditions, can most of the time point out and say, when I eat that, I feel like crap the next day, right?
Yeah, for sure. And I mean, it has a lot to do with the breakdown, and they're not fully understood of why it is that, you know, it leads to that increased inflammation, but it has shown that high fat diets, the bad fats, the sugars, alcohol can inflame these specific conditions. And so it's prudent to avoid any sort of inflammatory food when you have a condition such as this, because one flare up or a few flare ups in a row can really put you down into a bad path. Anyone who has AS knows that it's a condition where you have to watch what you're eating and you have to watch what you're doing, and you have to make the best of the good days.
Yeah.
So for the next thing, I mean, there are things you can do like postural and mobility exercises. So you want to keep your joints healthy. You want to keep your joints moving, and you want to keep your chest moving as well, because again, it's one of the conditions that attacks the ribs, and so chest expansion will be reduced. So you want to make sure that you're doing deep breathing exercises, thoracic spine mobility exercises like cat camels, um, and fire hydrants, kickbacks, pelvic tilts, gentle SMT, very very gentle SMT, moving the joints through a passive range of motion, getting that movement there,
Yeah.
and as well doing a little bit of soft tissue. Dr. Roach, do you want to cue in on a few other
Yeah,
nuggets?
I mean, one thing that I would say, like I'm fairly aggressive on like my patients that I've seen. Once you know the X-ray and where the patient is fused because of the AS, the parts of the spine that aren't, I mean, there's just fair game. And what you want to do is through chiropractic maintain the mobility there, because that part of the spine is working extra hard, because none of the vertebrae below that are fused have any mobility. So if you're fused from T12 down to your pelvis, T11 is moving a heck of a lot more to try to compensate for all the movement that you do throughout the course of the day. So that would be one thing that I would recommend with people that have AS. Find out exactly through a chiropractic examination and x-ray and everything that we do, exactly which vertebrae are actually fused, and the rest we need to keep mobile. Two, find out a exercise regime that is the right amount for you, because what we know with AS is that when you do too much, you run the risk of inflaming things, and people get discouraged and say, oh, I was doing biking, I was doing that, and I can't do that anymore. Well, it might just have been that they were doing too much. You got to find a routine that you're able to do on a daily basis, whether it's just spinal mobility thing, but even aerobic exercise and stuff that you can do that's a little bit more advanced. You got to find a way to do that in a way that it's not too much every single day. So the word pacing is very important, where you pace yourself and doing stuff that you know is a routine that is doable for you every single day.
Yeah. Great point. And just to move on to the next bullet point here, ergonomic changes. So if your environment isn't proper, if your environment encourages this curve, encourages this structural malalignment, then things need to be changed because you have a condition that's also working against you. So you have to be in control of the things that the other stressors that are more controllable than a intermittent inflammatory condition. So
Yeah.
changing the environment to help meet the needs of your body is hugely important.
One of my patients that I had about 10 years ago, his name was Jim. And then Jim came in with AS. You know what his job was? He used to work in a crane high up in the air where everything was below him. So all day long, he was looking down in between his legs, running the control, right? In terms of getting, that rope down exactly where the people underneath needed it to carry stuff. So definitely an ergonomic position that fed the ankylosing spondylitis because he spent the whole day with his head down, looking down at the ground from 300 feet above, right? So definitely a great point where you need to make changes to your lifestyle and your job and your position every day so that you're not fast forwarding this whole process quicker than what it can go, what it's naturally going to go if you make those changes.
Yeah. So diets, just to touch on that top point again, I have a few bullets for you guys. Diets with omega-3s are really good. There was some research conducted that it does help people with AS. And so foods that you can get omega-3s in, flax seeds, walnuts, soybeans, cold water fish like salmon and tuna. And you also might want to maybe practice a regime where you're trying to figure out which foods are causing your inflammation. Again, we can go back to an inflammatory diet or an anti-inflammatory diet or an elimination diet where you're trying to eliminate out certain foods and then adding them back in to figure out which one was causing that inflammation. So it's a little tip and trick to try and reorganize your diet a little bit.
And FYI, conditions like AS, not too not too different than rheumatoid, which are now being called autoimmune. It is not uncommon for these conditions to be with autoimmune disorders from the thyroid, so to speak, like something like Hashimoto's. With Hashimoto's, if you are gluten sensitive or you have gluten intolerance, any amount of gluten will basically destroy your thyroid even faster because with Hashimoto's, right? It's an autoimmune disorder of the thyroid. The reason I say that is because typically autoimmune disorders hang around other autoimmune disorders. So if you have AS or rheumatoid arthritis, it's not uncommon to see other things. So if that's the case, then any amount of gluten you're going to eat is usually going to create an inflammatory response that your body is then going to try to fight. And then you start to run the gamut of having inflammation throughout the entire body. So, you know, definitely the same cells that will attack the gluten will attack your thyroid because you have an autoimmune disorder called Hashimoto's, which tends to run with other autoimmune disorders, which could be rheumatoid arthritis and MS and all these autoimmune disorders. So just wanted to point that out.
Yeah, yeah. Diet plays a hugely important role and is something that should always be considered. You should always look towards eating a healthier diet or eating healthier foods, I should say. Diet is a word that's thrown around way too much, but eating healthier foods, make an effort to adopt better foods that are good for you. Good
Yeah,
stuff.
cool. So yeah, so give us a few hearts there, guys, if you've liked this information so far, and definitely comment if you know somebody that has AS because it is not that uncommon. So just comment yes if you do know somebody who has AS, and that would be greatly appreciated because it gives us an idea of, you know, how good our topic choices are, because we want to definitely talk about stuff that's common. And lastly, at this point, before we forget, let's have you share this episode, because you might have somebody that you know, or somebody that just want to know about AS. So thank
Yeah,
you. Yeah, we got a
really
few.
important. Yeah, Sonia, yeah, great point. Something that works for one person may not work for something else. So there's a famous quote from one of my profs at chiropractor college, and he used to say, "Different people are different.
Yeah.
Different people are different." And in chiropractic, we know that one adjustment with one person might cause the issue to resolve quickly, whereas sometimes it takes a few adjustments for an issue to resolve. And so we understand different people are different. And when it comes to diet, most importantly, yeah, one regime might not work for one person as it did for somebody else, and so that needs to be considered. Um,
Totally.
and accountability partners, again, great point, Sonia. Great point. Having somebody, especially when we were doing this in the beginning, we were talking about New Year's. What was it, Clayton? The New Year.
um I forget, what did I say?
It was so clever. The new year, but the new year, new me, right? When you go into a new
Yeah.
year, you got to have accountability partners that are on the same level as you, right? And so if you have one person who's gun ho to go to the gym that next morning, or to go for that walk at 6 a.m., and then they go and they message them at 10 to 6 and they say, "Are you ready?" And the person doesn't wake up. Well, that's not really the right partner that you want, right? You want somebody who's going to hold you accountable. So yes, accountability, hugely important.
All right. So the supplement of the month, we're going to talk about omega-3 here. We've done this one before, but we thought it would be very important, being the topic that we're talking about tonight, which is inflammation and inflammatory arthritis. Definitely omega-3s can play a role in that. This is one of the supplements where I kind of, tell people to spend money on, because the last thing you want is be taking an omega-3 that has rancid fish oils in there. And fish oils become rancid very, very easily, just by exposing them to oxygen. It's a process called oxidation. And the process from catching a fish to extracting the omega-3 and putting it into a fish oil that we can take takes time. The shorter amount of time that is, the more fresh the fish is going to be in the supplement. And I can tell you without a doubt, if you are taking an omega-3 that you are burping, or that has a smell, it is not a good omega-3. So some omega-3 companies take about 12, 9 to 12 months to go from catching the fish to the pill. You break that pill open and it smells rotten. Okay. So be very careful where you're buying your omega 3. Make sure you take a very good omega 3. And there's actually companies right now that are working. Actually, one of my patients is working on an omega 3 from algae, which is very sustainable instead of killing fish, which actually don't have a lot of omega 3. And you need to kill a lot of fish in order to get omega 3. So definitely anti-inflammatory, very, very good for brain health as well.
Yeah, yeah, and they're actually recommending that children have enough omega-3 during their developing years up until the age of 12, and even continuing on for that proper brain development.
Yeah.
And just as an example, like I have the NutraC omega-3 product right here, and as you can see, it is a fairly large bottle, and this is the liquid version. You can get the capsule versions like Dr. Roach was talking about, but this is the liquid option. And it is a great, great, great product. Again, all of our products are that you can get at the clinic are high absorbency rates and great quality products. And so if you have questions about these and how to get them, contact the office.
And with a liquid, you're exposing everything. So basically, if it's rancid, you wouldn't be able to hide it. If it's not a capsule, so the product is going to be good. And definitely, one thing too with the bone density, right? Very important as well in terms of bone health. And actually, they use a lot of omega-3. This company actually does a lot of omega-3s for animals, for dogs.
So yeah, because NutriC, Clayton, is this a Canadian company, Nova Scotia,
Yeah, it is
Dartmouth?
a Canadian company. It used to be called Ocean Nutrition, and they were bought over.
Yes.
And Ocean Nutrition was basically founded by a local person here. His name is called John Risley, who used to started Clearwater Seafoods. He started Ocean Nutrition and then sold it off to another company. But in terms of where people get their omega-3 for these supplements, the biggest company is actually in Denmark. So a lot of the better companies deal with Denmark and some of the other followers you just don't want to buy from. So yeah, definitely for kids, very important. I mean, we eat less and less fish in our diet. So, it's kind of second nature to us being from Cape Breton, or if you're raised up close to the water, fish is a big staple in our diet. So, maybe it's a little bit more forgivable there if you're not taking omega-3, if you are taking a lot of fish in your diet, but it's definitely not common now, especially not something that's, not farmed, right? So you don't want to be taking farm salmon. You want to eat wild fish. So, how much omega-3 should you take daily? If you're taking this supplement, it would be about a teaspoon a day, right? So, the one that Ben showed you, would last you around 2 to 3 months.
Yeah,
And if
and
I'm not
it's
mistaken, it's about per teaspoon,
it's 1250,
1250, right?
1250 milligrams.
Oh, there you go, right there. Yeah.
Yeah, right on the bottle there, it tells you the exact equivalent that you should take,
Yep.
and it is 1 teaspoon a day. And Alicia just wrote in the comment section there, we also have this product in capsule forms, but it takes more capsules to get the equivalent of
Yep.
1 teaspoon of liquid. And so we normally recommend liquid.
Now, somebody with AS, I would tell them to take 2 teaspoons a day. Like it's a no-brainer, right? You need to get that as well as, other anti-inflammatory things, but
Yeah,
definitely. A lot of the concepts that do apply to AS also apply to other things, because a lot of things that we spoke about are generic. Eating an anti-inflammatory diet. Do you really want to wait till you're full of inflammation to figure out that you need to eat an anti-inflammatory diet? Like, that's something you should be doing every day. Exercising, good nutrition. And all we wanted to do is speak about this because it is somewhat fairly common. And a lot of people don't find out it's AS until they've eliminated everything else, and then down the road figure out that they've had it. But you can shorten that diagnostic process if you somewhat follow what we've talked about tonight. So I hope you appreciated this. If there are any questions throughout the weeks, guys, never hesitate. We are here for you guys. We're doing this for you. We obviously know this information, and we're sharing it so that you become a little more aware of your world. And if something is asked to you by friends or colleagues, you can refer them to Hump Day Conversations, or maybe you can answer them because they're asking you a question that we've touched on a previous Hump Day Conversation. It might be even for you when you go to your medical doctor. Maybe you are now more engaged, or you're asking better questions because some of the things that we've discussed. That has been our goal all along, is to educate you, because with more knowledge comes more power, and with more power comes better decision making processes. So yeah, I don't know what your thoughts are on that, Ben, but that's what I want to say tonight.
absolutely. Yeah, that's definitely why we do Hump Day Conversations. And for those that are new to Hump Day Conversations, welcome to the conversation. This is, the 26th week that Dr. Clayton Roach and myself, Dr. Ben Boudreau, have been doing these conversations, informing and educating patients on the positive aspects of learning and asking good questions, and having better conversations with your healthcare providers, so that they can give you the answers that they want to give you. Um, as well, at the same time, I mean, these topics are coming because of the organic nature of the way the conversations are flowing and where you guys are directing us to go. Question nights are a great night because they help us sort of get into your heads and see, okay, well, where's everybody at? Because we don't want to meet you where we are. We want to meet you where you are, right?
And just to touch on that a little bit more, is the reason we're doing this talk tonight is because of a question that came up the other day that we felt we needed to expand on a type of arthritis that are out there. So please tonight, guys, if we can just, as a group, go out and share this episode, every single one of you, just hit share. No excuse. You now have an obligation because you know more than your neighbor. You know more than your friends. You now have an obligation to share, right? It does nobody any good to hold on to this information because you're now being selfish, because you might help actually somebody by disseminating this information out there. There is somebody out there looking for the information we share tonight because they might not know what's going on, but they know they have some kind of inflammatory arthritis, and tonight might be able to clarify that process for them. So please, please, please go ahead and share this episode. We could share something with somebody who's living in Ontario, but if they're getting help, that was our goal, is to help somebody, get the information, get further help that what we can provide here, because they're just not here. So I want to thank you guys for everything you've done so far and sharing the episodes, because definitely Hump Day has grown more than we thought it was going to grow. And we actually enjoy Wednesday nights. And so thank you so much.
Yeah, definitely. Thank you guys. And just a quick, before we get going, we want you guys to share these conversations because, our deepest desire is that someone sees this, they say, oh, I have something like this, or I've been feeling this way, and I just haven't, had the confidence, or had, maybe I didn't think there was really something that serious wrong with me. And then our deepest desire is that they go and get checked, and that they find out that they, have something wrong, and then this is what they can do about it to help improve their quality of life. And so at the end of the day, we just want to improve the quality of lives of people near and far, people that we meet, and even people that we don't meet. So this is what it's all about.
Perfect. Well said, Ben. So we were leaving you tonight with a big thank you from the bottom of our hearts for being here every night. We see people again and again that I don't think have missed one episode. So it's beautiful to see. So if you're looking at this on YouTube, make sure you hit subscribe. We're getting more and more subscribers on YouTube, which is great because it is another way to view our episodes. We post these the following morning on YouTube. And so please make sure you subscribe on YouTube. And if you are watching tonight, if you haven't done it yet, make sure you share the episode. And if you're watching this later on Facebook, make sure you share it again. Okay. So thank you so much, Ben. Thank you so much for the presentation tonight and some of the information. And we're getting close to solidifying the interview or the special guest for our next interview type of Hump Day conversation. So stay tuned for that. Thank you guys. Have a great night, and we will see you soon.
What's up, guys?
Listen, if you like this episode, you'll probably like the other ones. Chances are pretty good. So here's what you need to do. You need to like us and follow us on Facebook. Following means you get notified when these two guys
are live.
Next, family, friends. You need to share these episodes because you never know. You might help them because they need this information as well.
And guys, if you ever miss an episode, make sure you subscribe to us on YouTube. That way you can watch the episode over and over and over again.
Guys, we love you and appreciate you.
Take care.